All right, well, I am Doug Franzen, and I'm here to talk to you about the National Clinical Assessment Tool in Emergency Medicine with my co-collaborators, my partners in crime, Kathy Hiller from the University of Arizona, Luan Lawson from East Carolina University, and Julianna Jung from Johns Hopkins University. And we're going to talk a little bit, not only about the NCAT itself, how we built it and how it was made, but also how it's currently being used and what educators think about it so far, as well as present some validity data. We have a consortium of schools that are using the form, and we are collecting data on that, and we've put together a whole academic year's worth of data that we recently finished analyzing, and so we're going to present some of those results. So the NCAT-EM is the National Clinical Assessment Tool for Emergency Medicine. It is the first assessment tool in emergency medicine that is national, derived by expert consensus, specialty specific, and focused on clinical assessment. Right? We have other standardized assessments in emergency medicine, like the Emergency Medicine ACE exam from NBME or the SAEM M4 examination that a lot of clerkships are using. But this one is really the first standardized clinical assessment tool focused on clinical work in emergency medicine. And this was put together in 2016 at the Cord Consensus Conference in Nashville. We had over 100 educators there representing both undergraduate medical education as well as graduate medical education, where we started off kind of talking about key themes in assessment, just what sorts of things are important to assess, what sorts of things are being assessed, how are we assessing those things, how should we be assessing those things. We talked about current practice versus ideals, and then actually drafted the tool during the consensus conference. We figured out almost all of the different domains and how we would assess them. There was a few areas of disagreement that we hammered out via a Delphi process after the conference, and the form was finalized in early 2017 and published in the WestGem supplement in January of 2018. People actually started using the form almost immediately after the consensus conference. We had a lot of interest right away from people who were interested in using it, and it's been used at a lot of places, as Kathy is going to talk about. A little bit of background of why we did this. We started off almost over a decade ago, a long time ago, all kind of frustrated with our own institution's assessment tools. I was frustrated, I remember, because my medical school said, you have to use this assessment form that's being used on every other clerkship, and I said, most of these areas don't make any sense for me to evaluate. Why can't I have a little bit of freedom here? And we all had similar frustrations, and so we started working on student assessment in general. And as part of that, one of the things that we did was we collected a bunch of shift evaluations from medical schools around the United States and just analyzed them and said, how is this school assessing students? How is that school assessing students? And one of the things that we realized is there is no standardization. And when your students go on an away rotation and get a high pass, that may mean something very, very different from a high pass from a different school. It may be equivalent to an honors or a low pass at a different school. There's really no rater training, no calibration. There's unknown reliability and validity. Nobody has really looked at their, the statistics on their assessments and how they're fitting together. And so when you're on the program director side of the table and you're looking at a SLO or you're looking at a set of student grades and you think maybe you're comparing apples to apples, it's not true. And you're, in fact, not even really comparing like apples to pineapples. It's more like comparing apples to pineapples to narwhals, because the assessment process is just so very, very different. And there's really not a good way to look at one student compared to another student if they haven't rotated at the same institution. So we were very glad that once we started put this thing together, that people jumped right in and started using it right away. And next up is Kathy to talk about how it's being used.
Thank you, Doug. Yeah, I think that you perfectly set me up, and I don't know, was anyone at the consensus conference in 2016? It was so fun. There was an entire room of like 100 people, super engaged, program directors, medical student directors, students, dean's office representatives, cognitive psychologists. It was really very engaging and energizing for our group. And immediately after the conference, people wanted to use this form. It is being widely adopted across the country. We have established a research consortium that includes 13 sites at this point, but we know that it's used at least twice that many places across the country. And in fact, when we poll CORD and CDEM members, about 2/3 of them have actually heard of the NCAT. And of those who know it, about half are using it. So it is a very popular form. One of the things that we didn't really anticipate as a side effect of the conference was even people who aren't using the form are actually modifying their own form based on what we did at the conference. So the impact of the NCAT actually goes beyond the form itself. People find that it's about as easy as their own tool to use, their own institution-specific tool. One person said that it was harder. We don't know who that is, but I'd love to know why. And looking forward, those who knew of the NCAT, again, plan to use it next year with or without any modifications. And as I said, those who are using their own locally derived assessment tools modified them in response to what we did at the consensus conference and in response to the NCAT form. All right, so it's adopted. People like it, which we are happy about. But just because that it's popular doesn't necessarily mean it's the right thing to do. So at this point, we felt like the next step was to make sure that we establish some reliability and validity evidence for its use. I'll hand it over to Dr. Jung.
Thank you. So, as Dr. Hiller mentioned, we established a research consortium so that we could collect NCAT data at multiple institutions around the country, multiple different kinds of clerkships, different levels of learners, and really see how it performs out there in the wild. So a huge thank you to our 13 consortium members. I heard that one of you in the room is interested in joining us, and we would be thrilled. But what we have so far from our 13 institutions are over 6,400 assessments of 748 different students. So we have a large amount of assessment data covering a large number of students. And our goal in amassing all of that data was to analyze it, to look for validity evidence for this tool, to see how it performs, to see if it's being used effectively, and of course how we can make it better. So just looking at the raw score distributions up front, the tool has 3 components: entrustability scales, which are your sort of traditional domains: history and physical, differential diagnosis, formulation of a management plan, observation and reassessment, emergency recognition and management, and communication skills. And you can see, so lighter blue is a lower performing student, darker blue is a higher performing student, and we're seeing a little bit of a right-skewed bell curve here. We're seeing relatively infrequent use of that pre-entrustable lowest category, but pretty consistent use of the mostly versus fully entrustable, and then a small set of students at the top who are recognized as outstanding. And that's about what we expected to see, and we're happy to see this result. There's also a global assessment element that is more comparable to the SLO. So compared to other students you have taught at this level of training on this shift. So a little different than the SLO. We're not trying to summarize every student in history. We're not trying to summarize the student's entire rotation performance. But we ask for a stratification by tertiles. And once again, relatively infrequent use of the lower third category, consistently high use of the middle and top thirds with a smaller group of outstanding students. And I just want to mention that SLO score distributions have been looked at in recent research studies, and our distribution that we're seeing here is very similar to what's seen on the SLO, which is a nice little nugget of validity evidence that our individual assessors are sort of capturing the same dimensions of student performance and stratifying students in the same way as our summative end-of-rotation assessors are. We also saw that students who had lower entrustability scale scores, so students who perform poorly here, also perform poorly here, which is what's expected. We have a section for professionalism where we ask raters to indicate if there are professionalism lapses in multiple different domains. What we found were a relatively small number of professionalism lapses, so less than 1% of our 6,400 evaluations documented a professionalism lapse. But of those, there was one in every subcategory. So every way a student could fall down in professionalism, somebody did. The most common ones were punctuality and attendance, as well as initiative and diligence. So that accounted for a majority of our lapses, but we did see lapses in ethical conduct and other very serious domains as well. Very importantly, we saw that students who had professionalism lapses scored significantly lower in the other domains of assessment on the form. So those students who were deemed to be unprofessional were more likely to be rated as pre-entrustable in the individual skill domains or as lower third in the global ratings. Once again, another little nugget of validity evidence, professionalism linking up with these other categories of performance. As far as our reliability data go, we saw excellent reliability within institutions. So each institution was doing a really good job of using the tool in a consistent manner. Unfortunately, we saw very significant score differences between institutions. We actually had ranges in terms of average entrustability scores from 58 up to 79%. So a big range across different institutions. And what that tells us is that there are institutional factors that have nothing to do with student performance that are at play in how we assess students. Those factors might be curriculum, they might be assessment culture, they might be assessor training and calibration, but there is something going on at the institutional level that interferes with generating comparable data across institutions. The last analysis we did was Factorial ANOVA to look at sources of variance within the data. And the real purpose of that is to sort of separate out, are there subgroups that perform differently than other subgroups? And is that what you expect? Is that what should be happening? Because if it is, that lends credence to the idea of validity. So for example, our M4 students were uniformly rated higher than our M3 students. That's good because we hope that our M4 students have learned some things and are going to be able to outperform their more junior colleagues. So that's a piece of validity evidence. Similarly, we found that students who are planning careers in emergency medicine had higher overall scores than those who were not planning careers in emergency medicine, which once again makes sense. You know, students who are planning a career in the field are going to be invested, they're going to work harder, they're going to have a broader knowledge base, and it's likely that they're going to outperform those who are simply taking the rotation as an elective or required experience without planning a career in the field. Like I mentioned before, though, we did have some unexpected or undesired sources of variance, including institutional variance, which I've already discussed. We also found that assessor factors influenced ratings. So generally, faculty rate more leniently than residents. And we actually found that however, that junior faculty are among our most stringent raters. So clinical instructors, the ones who are like brand new attendings, are not tolerating any nonsense, and they rate significantly lower than their more senior colleagues. And we also found that PGY3 residents, for whatever reason, seem to be particularly hard graders, with more junior residents and actually more senior residents grading more leniently. There were some things that were not sources of variance that we were happy about, one being gender. We certainly did not want to see a uniform influence of gender on student performance, and we did not see that. However, we did actually see statistically significant differences within institutions. Interestingly, those differences went in both directions. There were some institutions where women were systematically rated more highly than men, others where it was the converse. So each set of institutional data is obviously much smaller than the broad data set. These might simply be sampling error. They might not be trends that persist over time, but it did tell us that we need to look very carefully at gender disparities in evaluation, both globally and at the institutional level. We were disappointed that prior emergency medicine rotations did not contribute to higher student scores. We had hypothesized that the more EM you do, the more EM you know, and the better you'll do. However, when we thought that through, we recognized that there's a big institutional learning curve when you do an away rotation. You spend probably half your time figuring out the EMR and who to call for an admission and how to get a VQ scan, and all of those things are going to interfere with the global picture of your performance as a sub-intern. So it's possible that it's not so much a knowledge factor as it is or a performance factor as it is an institutional phenomenon that we're not seeing differences with greater experience. We also saw that faculty seniority did not necessarily play into faculty grading patterns. So rank did, but years in practice did not. So end of the story, the first thing we wanted to emphasize is that this can be done. So you can have a uniform assessment tool that is standardized across institutions. You can collect data, you can aggregate it, you can analyze it, and you can learn from that information how to do better across the country, which is super exciting. So if we got nothing out of this besides proof of concept, we would be very happy. We also are pleased that the tool yields a reasonable score distribution. It is right skewed, but so are our SLOs and many other aspects of grading in medicine. We did get some validity evidence, including the ability to differentiate M3 from M4 and EM bound from non-EM bound. But we are concerned about the fact that there are differences between institutions and assessor groups, and that really speaks strongly to the need to improve rater training, calibration, and standardization across institutions so that we can really realize the goal of being able to compare students from one institution to another and changing those narwhals back into apples. That's all I got. If anybody has any questions or wants to join the consortium, we're all up here. Dr. Hiller is our fearless leader, and she has been amazing. And you can get in touch with her as well if you need to take off. So thank you guys very much for your time.
Any questions?
I have a few questions. The average number of NCATs that are filled out per rotation, I saw it in the Western article they were talking about trying to have 6.
So the average number per student was 7 with an IQR of 6 to 10. So we actually were seeing a significant number of NCATs completed for each student.
So another question I have, I was trying to put together our own rating scale based on a lot of different fields of medicine. And when I came across the NCAT, they did have a comment section at the end. Have you noticed any trends in what they're using the comment section for?
That's a great question. It's on our short list for next steps. So we're actually working with a linguist to look at the comment section specifically as it relates to gender. And Dr. Franzen's working on professionalism comments because the professionalism assessment's actually a dichotomous one. So if you note that there was a professionalism lapse, comments are required. So he's analyzing those right now.
Another question I had is talking about how procedural ability really isn't doesn't play in how they perform in residency, and it wasn't really listed in that section. That you found people using that comment section to list procedural ability, or you just not care about that?
So I'll be honest, I haven't looked at the comments regarding procedures, but that's a really good point. I will say the discussion around whether we should include procedural competency on the form at the consensus conference was very robust, but there was a pretty good argument against using it. Some of the people who modify the form have included procedural competency as an additional domain. Yeah, keep going. Is anyone in the room coming after us to talk? Sure.
That's okay. For the slow letters, is anyone just citing the NCATs for the
I don't think I've seen any actually. I don't think I've seen any NCAT data on slows for this year, but it's definitely something we're working on. Yeah, we've entered negotiations with CORD, who is the body that really regulates what goes on the SLO, about including not only NCAT data, but also things like the EMA score, National EMM4 exam scores, more objective, less subjective data within the SLO.
Yeah, there have even been some very early discussions with the AAMC about very early discussions, but you know, people are clearly interested in more than just step 1 and step 2 scores. And you know, as you've seen with the SEI and some of these other initiatives coming out, program directors want to know more about their applicants, and we're trying to find ways to get them more data.
One more question. When you look at the instructors versus the professors, the academic faculty grading Arthur, do you have any sense of why that is?
So I can take that. We can't prove it, but you know, if we all think back to our own junior faculty days, I think junior faculty are in a little bit of a position of fear, right? They're not so confident in their own situation. They might feel a little bit more uptight about anybody who's documenting something wrong or suggesting something that's a little bit off, and I think that they might just have a tendency to be a little bit more critical of management. And they also don't have as much perspective, right? So those of us who've been doing this for 20 years have seen the whole breadth of what students can do, and we kind of can place a student mentally on the continuum of performance more easily, rather than just focusing on flaws. So we don't know for sure, but I think there are some challenges inherent in being a new attendant that might play into that.
And it's not necessarily a bad thing, right? So the repeated sampling is one of the ways that we're able to show robust data on student assessment. So we want students to be assessed by people who...
Maybe they have more contact with the student.
That's interesting. We hadn't actually thought about that.
And the other thing I want to emphasize is just because they're doing it differently doesn't mean they're doing it wrong. They may be the ones who are right and who are grading more accurately and who are paying more attention, right? As opposed to those of us who maybe are more senior and doing whatever senior people do, enjoying our coffees.
What have you noticed for people or how many people in academics? So like one of the things that I run into is little likes their 1 through 5 scale on the like on-shift scoring, and this is 1 through 4. So that's one of the things that I've run into in discussion.
So we deliberately made this a 4-point scale based on input from a cognitive psychologist, and in recognition of the fact that frequently everyone gets 4s. So that's part of the... So we deliberately made this a 4-point scale with the input of a cognitive psychologist because we recognize that frequently with 5-point scales everyone just gets 4s down the line. So we wanted to make sure that it wasn't just oh yeah, high pass, 4s all the way down. They needed to actually look at the anchors and figure out which domain, which rating scale they fell into.